Very good. So here today, thank you for having me. We're going to be talking about the bigger picture. I won't be talking about AI, but I will actually talk about standards too, because that is a hot topic. So just to start with there, I also want to thank Krista for taking 10 years off my age by doing a little work there. Thank you for harvesting the right picture from LinkedIn. And so just want to take a starting point here about who is Ontario Health. People know their hospitals, people know their doctors, they know their pharmacists, but behind the scenes there's a large organization that came into existence in 2019. So that was an act of legislation that brought together in the Connecting Care Act a number of agencies, Cancer Care Ontario, eHealth, the Gift of Life Network, to create a agency that really is the full picture. And so at Ontario Health, really the overarching intention is Ontario Health is the health system operator. We don't deliver health care, but we fund it, we coordinate it, we sponsor programs, and we bring together a lot of the machinery to support that. So that's the bigger picture. The other recent addition to us is really home and community, our Ontario Health at Home. Recognizing that there's healthcare, but there's a very important relationship when you think of the broad spectrum of services that people need for healthcare that brought together Ontario Health at Home. So a number of things that are highlighted here, but I'll just poke at a couple. Specifically, the digital health infrastructure, that's a big part of what I'll be talking about today. That's what we really use to bring together a lot of the data and move it around the province. The other things that the agency does is really sponsor the bigger programs that are province-wide. E-referral, centralized intake would be a good example, where MRI is a priority in that context. Patients before paperwork is another one. So really it is all intended to be a big encompassing organization, but at its heart, it is really about performance management and delivery through many partners. So inside Ontario Health, we have the digital part, which is actually the greatest or the biggest number of people. And we have within it the electronic health record, which is created in legislation. But really the overarching goal of the electronic health record is to create a complete longitudinal record for every Ontarian. And we've been at it for quite some time, and we've made a lot of progress, and I'll speak to that in a later slide. But that's really foundational in terms of moving data around, collecting it, and getting it to places where it's actually needed next. Going to the other point, enabling our priorities, e-referral, patients before paperwork, population health, again, key things that what we do. And then earlier we talked about some of the programs that we do through delivery partners. The cyber program that Kashif talked about earlier is a big success, but just a good example where we create the circumstances but work through others to get the job done. So, bit of an eye chart here, but just to make a couple points about the size and the scale of what gets done at Ontario Health. And I'll point first to the client registry, because that's the heart. We really collect every MRN from every hospital. We have every health card number, and that really is what knits the system together to say, who is the patient? Because that is the first and most fundamental question. Within that, we really have a couple big repositories. Labs, I would say, is our flagship. It is a complete repository. Every lab in this province goes into OLIS. It's a complete data set. Medical imaging, every hospital is contributing to our medical imaging infrastructure. Clinical data from the hospitals, not quite as complete because there's a lot of decisions made, but I'd make the point every hospital except for one is contributing to the acute and community CDR. We also operate the CRIS system for home and community. So bottom line, big picture, there's a lot of data that we have, and the job for us is really kind of liberating that and moving around in digital. And then just to kind of position this, Ontario Health, really we're the system operator, we're the accountable party, we're responsible for the governance, For big provincial contracts, we're the ones who run that, and overarching responsibility for the financial sustainability. But more importantly, we don't do this all by ourselves. And when we take a look at medical imaging, OCINet is our anchor partner. They're the ones who are doing all the lifting for us and moving us forward into the future. So with that, I'll turn it over to Michelle.
I had a chuckle when I arrived today and I saw the height of the podium. I'm like, good, I can hide. And then I noticed it was clear. So here I am. Thank you, Phil, and thank you to everybody for welcoming us today. As Phil noted, OCINet is a partner of Ontario Health, and we work more at the operational level of delivering on the medical imaging strategy. OCINet is a fairly young organization. We only came to be in 2022, which is not that long ago, 4 years ago. And prior to it, though, there's been a long history of evolution of medical imaging in the province. In 2007, starting with the emergency image transfer system, then there was the build out of 4 very independently operated diagnostic imaging repositories, evolving into the first regional PACs in Southwest Ontario and Northern Ontario, and a little bit of consolidation of 4 repositories down to 3. So in 2022, OH directed that there would be one operating arm, one consolidated organization looking after consolidating operations of all of those individual arms and bring it into one entity. I'm also old school, I like my paper. So what does OCINet do? We're a pretty small organization, pretty lean. We're about 60 people. Of technical and clinical experts, I would call us. But our portfolio is quite wide, as you can see from the diagram. I'm not going to go into all of it, but we have some foundations that drive our principles across the top, working with our clinicians, working on with clinical expertise and advisory. We really do pride ourselves at OCINet on working with clinicians across the province. We bring our expertise to the table, but we rely on the clinical expertise of the clinicians in the province to help us drive where we're going to. We don't work in isolation. I think that's the joy of what we get to do is collaborate with a lot of people. We have a clinical advisory committee, which helps also continue to drive us forward in terms of direction. And we're looking forward to reboot that clinical advisory committee as we change and evolve to things that Phil's going to talk about to get other types of clinicians at the table. We do have a very strong focus on privacy and security because we do oversee a lot of data. In our role, we're the HIMP, my privacy officer over there, she'll probably laugh at how I say that, but we're the Health Information Network Provider, and the hospitals and the other organizations remain what's called the HIC, the Health Information Custodian. Why is that important? We, as the HIMP, can give access to the images and the repositories for clinical use. Only, period. We cannot provide it for secondary use unless the hospitals give us permission, be it through a REB-approved research study or an AI vendor at the table. Those organizations have to give us the approval at this time. Underneath our foundation, we have a whole arm of what I would call technical infrastructure and technical expertise who work on system enablement, technical integration, vendor management, day-to-day operations, data quality, error management, all of the stuff that is incredibly complicated across the middle tiers. So we have a really strong technical team and a very strong clinical team, and we are very focused on ensuring that our clinicians are served responsibly and also dealing with them responsibly within the needs of their workflows. Most of the hospitals in the province use one of the 3 DIRs as their long-term archive, so it is important that we have noting that we have the only copy of their data. One of the key things we've heard about a number of times is change management. The OCINet team also does change management and onboarding of organizations into the repositories, and a lot of re-onboarding. There is a lot of HIS replacements, PACS replacements, risk replacements, consolidation going on across the province. It's quite a busy environment right now, and our team is involved in that change management and onboarding. So where are we at today? I'll get to do today, and then Phil will take you through the future. So a little bit of a busy diagram, but we have, as you know, all hospitals now have PACS systems for quite a long time, and all of their images and and reports are stored in about 60 different instances of PACS across the province right now. So there is a fair amount of consolidation going on, and we are seeing a trend with more consolidation and regionalization around the PACS world. On the integrated community health service center side, the smaller non-hospital-based, or actually some very large non-hospital-based imaging centers, there are over 700 or 800 in last count, I think. We don't know how many PACS are in use, but we do know there's a whole number of them. We are actually going through an exercise right now to try to inventory that and get a better handle on what is actually out there, because we'll need that for the future for where we're going. As Phil said, 100% of the hospitals contribute their images and reports to the diagnostic imaging repositories, which is fantastic. Check for that mark. But we only have about 20% of the integrated health services centers contributing. So there's a lot of imaging that we don't yet have in the repositories. So it's a complex current state. It's a little bit fragmented, but we're getting there. From the diagnostic imaging repositories, reports flow to what's the bottom left corner, an item called the Diagnostic Imaging Common Services. And I would articulate that as the provincial-wide access to the imaging longitudinal record, which is another great piece, but it requires a number of viewers to look at reports, depending where you are in the province, and a number of different viewers to look at images, depending where you're at in the province. So again, some more opportunity for the future. I like numbers, so we'll give you the DIRs at a glance. You can see geographically where the three DIRs are. We have about 16 million studies contributed annually, which is about 1.8 petabytes of data. That's a lot of data. We replicate it because we need it for redundancy, and so that's about 3.6. In the approaching 20 years of contribution, there's about 13 petabytes of individual studies in there, or 26 petabytes replicated. And that's about 200 million exams that are in the current repositories. So a fairly large data set, and we only have about 50% of the medical imaging images in the repositories. We talked a little bit about FEM. I'm going to talk about it a bit more, but we have about 1.1 million exams that are ingested, logged directly into the PACS of the hospitals annually. And I'm losing my page. Sorry. Where are we at? What's important about FEM right now? It's a really important workflow. We don't want to be redoing studies. Thank you, my friend. We need to do a prefetching, intelligent prefetching, and ad hoc requests. So it wouldn't surprise you all that we are doing a little bit of AI enablement in this area. Our current FEM tooling is using some AI enablement to look at relevant priors based on modality type, procedure mapping, and body part, which is a new model that's continuing to learn. A step ahead, though, as you can see, and a perfect opportunity for AI enablement from the old world where you just took the last 10, 20, 30 images, regardless of whether they might be relevant, and you prefetched and sent all of those stuff. So we can be much more intelligent in this area. The one downside of the current FEM world is that FEM operates on each repository. It's not across all of the repositories, so we have some work to do there. I said that we have about 50, maybe a little over 50% of the province's medical imaging in the repositories. That's great, but it also means we have about 50% that's not in the repositories. So a large opportunity. And without that 50% from the independent organizations, the ICHSCs, the Provincial EHR is missing a lot of data. It's got a big gap in terms of imaging. And we have limited visibility into community-based imaging for the hospital clinicians. And sometimes that drives repeat studies and all the other fun stuff that happens. And we're working on that, so hold any questions you have on that. Phil's going to talk about the future for what we're doing around the ICHSCs because it's really quite exciting. So there's been a lot of work done. I look at it as fantastic work that set us up for success in the future. We have a lot of the OH and OCINet teams here, and I'd like to thank them for everything that they've done for the province to date, and they're super excited about where we're going. But we have challenges that we need to solve with where we're going. We need to make all images available. We need to onboard all of those ICHSCs so that we have the other 50% of the medical imaging volume available, and that we're able to use community-based imaging as one mechanism to do things like reducing wait times. Use the opportunity and the modalities that are out there. And then how do we add more clinical value? We've heard about digital pathology. What about other ologies? What about other endoscopies, oscopies? wound imaging, all of those sorts of things. What are the other opportunities that should be held within where we're going with a medical imaging EHR? We need to complete the AI FEM rollout. We need to look for other AI opportunities. So we've got a really good foundation that's been built over 20 years. And now we have some exciting stuff that we're going to go to in the future. And I'm going to turn it back to you, Phil, to talk about future.
Thank you, Michelle. So as Michelle said, there's been an incredible amount of work done, but there's still a lot more work to do. So the first step when you think of a bigger picture is to lay the foundation. And that's really the bigger steps that we're starting with right now. And I always kind of like this picture in particular because that picture that Michelle showed before, which was very confusing, too many objects, I can't understand it. But this one's easy. I can see three things that matter. And so when we look at where we're going to end up, and it's going to be a complicated orchestration to go from the 3 DIRs and DICS to one VNA, and that procurement is in flight at the moment, hoping to close relatively soon, and one, we'll call it metadata repository for reports, orders, and image manifests. And what will anchor all of this is really the stuff on the right-hand side. I alluded before to the Provincial Client Registry as the core that will allow us to resolve the patient. I'll just point out the other one here. Provincial Terminology Services will be super important for procedure codes, modalities, lateralities, to really knit a fulsome picture together. And so this is where we're really trying to get to. This is our North Star, to get to that next level. And that foundation then is what we will then use to actually address the bigger picture. So step one, it is the consolidation of the 3 diagnostic image repositories. It's a 2-part play. The MICDR work is in construction right now, and a lot of work already done by OCI Net 8 to feed that MICDR, but the bigger piece will ultimately be the establishment of the VNA and moving 20, 25 petabytes of data into that repository. And at that point, that consolidation will get us to really one VNA. The unfortunate part of all these transitions, we have to go to 4 before we can get down to 1. So the orchestration, hopefully we can do this relatively elegantly and do all the repointing and flowing things, but transition's hard, end state's clear, transition is messy. So the other key thing in the bigger picture, as Michelle made clear, we only have half the imaging in the province, we need the other half. And so within that context, we're doing a little bit because it's been a while since we've actually onboarded an ICHSC, so we're just kind of cutting our teeth at the moment to get that in. I'm going to talk about the DEC standards in a moment, but at the end of this year, we hope to have all the machinery in place to really ramp up and drive a concerted effort to have all of the ICHSCs contributing within the time period that the minister specifies. So just a little side note, we're an organization that in some respects are driven by legislation and regulation. This is really an important one. It's sort of buried in the regulatory world. But what this regulation actually says is all hospitals are required to contribute to the EHR. That didn't really exist several years ago. The building of the EHR has been very much a voluntary effort. Now it's enshrined in legislation to say you're obligated. If you have data that the interoperability spec supports, you need to give it to us. So hospitals, pharmacies, and quite recently, ICHSCs were added to this list. And so that's a regulatory lever, but that doesn't create the obligation. There's a 2-part process. And so this is when we get back to standards. In order to create the obligation, we're going through a process of creating the interoperability specifications to contribute to the EHR. They will be aligned with FHIR HL7v2 and DICOM, as you can imagine. There's always a little bit of tailoring for the province, but the bottom line is this is the process, and we're expecting to go through the DEX process this year towards the end of the summer. And really, the end outcome of that process is ministerial approval, at which point a timeline will be specified, and that will be the period of time in which the ICHSCs will be required to contribute. So our job then, in the intervening time, is to get the machinery in place, because that's a lot of work to onboard the 700 or 800 ICHSCs into this environment. So taking a big step back, medical imaging is one aspect of a bigger puzzle. We've got other things in play, for example, the comprehensive medical record for Ontarians. Privately insured medications are going to be going into the repository. Immunizations is going to be starting up. A big chunk of data that we're missing today is primary care. That has a tremendous amount of focus of the government and the primary care action team under Jane Philpott. So the bottom line is, I would make the point that the EHR has grown, and there's a lot of data in there. There's a lot of work to do, but it's very clear that from the top of government through the agency and all of the people here don't have to be told, the data is what matters. The data is what drives everything, and that's why we need to keep working on this mission. So just kind of in summary, medical imaging, a key component of a bigger effort to modernize. I just make a point as well, as part of our modernization, everything is going out of our data center. We're about a third of the way of getting everything into the cloud, so that's a big piece of it. Having a unified CDR here is key. I'd probably take a step back. We talk about the OLS repository, and we talk about the acute care repository and the drugs repository. The right way to really see this is we really have an EHR with a whole bunch of profiles in there, and that's what we need to keep adding to it. Endgame really should be a single endpoint to get access to every type of data in the EHR and appropriate APIs to complement on the .com side. So I guess the other key point here on the imaging side is now that once we have this foundation in place with miCDR and the VNA, what are the other ologies we go at next? We've got some cardiology clinics, for example, contributing to the ACCDR. It's not discrete data. We don't get the imaging. That's got to come into being. Digital pathology, Andrew Evans is part of the digital experts group at OH. That is going to be a focus of the province going forward as well. Ophthalmology, GI endo, all those things are coming into being. There's a lot of momentum, but the work that we're doing now is the foundation to implement that. And so end result, hopefully, is this is a big enabling platform for the province. Would like to also see some legislative changes to let data flow a little bit more easily around. But the bottom line is what we're really trying to achieve is an integrated system that supports better patient care. That's what this is all about. So with that, thank you very much.